I've been talking about PET in the planning of treatment of Hodgkin lymphoma. And PET is an interesting, fairly new imaging modality which is virtually always positive in patients with Hodgkin lymphoma. So it has become an important part of the staging of Hodgkin lymphoma, showing us more disease than we could see on ordinary CT scans. So patients are staged now with PET. And another interesting thing is that when we treat patients with chemotherapy first and then radiotherapy for Hodgkin lymphoma, then we can see the response to treatment much earlier in patients if we use PET, whereas if we want to see the response of treatment on a CT scan, it may take months or even years. So, because PET is a functional imaging modality showing the uptake of glucose in tumor cells. And it turns out that patients who respond well to treatment, they stop taking up PET, so taking up the radioactive glucose after just 1 or 2 cycles of chemotherapy. So we know that patients who do that, patients whose PET scan become negative after just 1 or 2 cycles of chemotherapy, have a very good prognosis with the standard treatment, whereas the patients who do not stop taking, whose PET scans are still positive, have a poor prognosis. Now, in the beginning, we thought that that would be a very clear-cut difference. And what I was talking about today is that with more data and with more research in this area, we've found that it isn't quite as simple as that. And it does depend on what kind of treatment. In particular, if we use more aggressive, intensive chemotherapy, the picture is not quite that clear. And the other thing is that we know that patients whose PET scan becomes negative have a very good prognosis, and we know that patients whose PET scan does not become negative have a poor prognosis, although that is not so clear. What we do not know is whether we could improve the outcome for patients by modifying treatment according to the result of the early PET scan. And this is still a question which has not been answered. Randomized trials are going on, and we are doing a large randomized trial in the ECCO lymphoma group in collaboration with 2 other groups, where patients with early stage Hodgkin lymphoma are randomized between the standard treatment, which is brief chemotherapy followed by radiotherapy, and randomized, that's a standard arm. The experimental arm, the patient's treatment is modified according to the result of an early PET scan. So if the PET scan becomes negative after 2 cycles of chemotherapy, then the treatment is modified so that we give only chemotherapy and avoid radiotherapy. Whereas if the PET scan is positive, we intensify treatment, giving a more intensive chemotherapy regimen and radiotherapy. And we have accrued over 1,200 patients, so we expect the trial to end fairly soon. And then, of course, we'll have to have some observation time to see if that policy will actually benefit patients. Mm-hmm. But until then, as I was stressing today, until then, modifying treatment according to an early PET scan is an experimental thing. You shouldn't do it outside of clinical trials. Well, that's another project that we have been working on at my department in my research group. We are investigating advanced technology in radiotherapy, in imaging and in radiotherapy, because we try to reduce long-term complications of radiotherapy by using advanced technology. And one thing that we have done quite a lot of work in is in respiratory adaptation of radiotherapy. By this methodology, we can register the breathing pattern of a patient and then adapt the radiotherapy to the patient's breathing so that we can, for instance, irradiate the patient in inspiration or expiration, whatever is optimal in the clinical situation. And the first group of patients that we investigated were patients with breast cancer, where we could show that by adapting radiotherapy so that we only irradiated patients in inspiration, we were able to spare about 10% of the underlying lung having a high dose of radiotherapy, and in particular with left-sided breast cancers, we were able to keep the heart and in particular the coronary artery, the left coronary artery, almost completely out of the treatment field. And when we had shown that, we went on to implement it as our routine treatment. So in 2004, we shifted to respiratory adaptive radiotherapy for all patients with left-sided breast cancers who needed their lymph nodes irradiated as well. So that is one thing where our research has actually come into practical use to hopefully the benefit of patients who will hopefully have no increased risk of heart disease on a long-term basis. At the moment, we are now investigating the respiratory movements of lung cancers, because we'd like to also, in lung cancer, to be able to reduce the margins of our treatment fields and thereby reducing the amount of normal lung tissue that is irradiated. However, it's much more complicated with lung cancer because we use an external marker to register the treatment motion or the breathing motion, but it has turned out, we have done research into the movements of the lung tumors, and there is no clear correlation between the movement of the external marker and the lung tumor. So, and lung cancer patients, of course, have much more irregular breathing and so on. So what we're doing now is that we are doing a project where we implant markers in the tumors and then do four-dimensional CT scans to follow the tumors and to register their pattern of movement and try to find the ideal part of the respiratory cycle to plan the treatment and perhaps also to deliver it. But that is some way ahead because it's much more difficult. Yes, well, head and neck cancer is a very complicated type of tumors. And we have been treating head and neck cancer with highly conformal radiotherapy, what we call intensity modulated radiotherapy, since 2000. And of course, when you do highly conformal radiotherapy, where the high dose volume fits very, very closely to what you have defined as a tumor, then it becomes critical that you actually know exactly where all the tumor tissue is. So we are now planning these patients with both a PET scan and a CT scan, and we use the combined information, sometimes also an MR scan, to have all the information that could possibly help us. Now we want to find out whether the contouring, the definition of the tumors that we have made are correct, or whether we could improve that by analyzing. We have a large cohort of patients now, and we are analyzing the locations of the recurrences to see if they were in the high dose, in the area that we actually defined as tumor tissue, or whether it was outside, so that we should have contoured more. And we are also analyzing the PET scans to see if areas with a particularly high uptake of glucose could perhaps point in the direction of an area where the risk of recurrence was highest. So this is a project that we have just started on. And in fact, the analysis of images in radiotherapy is now critical because we do these highly conformal treatments. And we would like to have more help than just us looking at the images. So we have actually formed a collaboration with our engineering university in Copenhagen. So one of our PhD students is a mathematician actually who is doing mathematical image analysis to try and develop models that would help us in the future to better be able to define the actual tumor tissue. Mm-hmm.